I'm going to discuss how the thyroid would affect voice. العلاقة ما بين الثايرويد والفويس دايما مشهورة. It starts from the undergraduate course. دايما احنا بنريفير للعلاقة ما بين الفويس and thyroid, especially in hypothyroid patients and especially in those who had thyroidectomy. However, العلاقة ما بين الثايرويد والفويس is much broader. I'm going to discuss the voice in patients who are hypothyroid, in hyperthyroidism, in patients who receive radioiodine ablation for hyperthyroidism, in patients who have viral or subacute thyroiditis, in patients who just have a goiter, and patients who underwent thyroidectomy. Starting with the first, the hypothyroidism, the most common endocrine disorder and the most common thyroid disorder, the hypothyroidism. So what is the relation between voice and thyroid? Actually, the larynx is an organ for thyroid hormones, and thyroid receptors are expressed both in males and females. And one of the most recent studies that tried to report the effect of hypothyroidism on the voice, they found that about 1/3 of hypothyroid patients, they presented with voice-related problems, namely hoarseness in 20% of the patients, vocal fatigue in 10% of the patients, and slurring in 2% of the patients. The average duration for suffering of these symptoms was 6 to 12 months before presentation to an endocrinologist. One of the tools to assess the voice is what we call acoustic analysis. And one of the tools used for acoustic analysis is Grab's scale. Using this Grab scale in hypothyroid patients, they found that hoarseness and breathiness were the two most affected voice parameters in about 70% of the patients, and the affection was mild to severe. Hoarseness is defined as alteration in temper, pitch, or loudness. Breathiness is an audible impression of air leak through an insufficiently closed glottis. عشان البرزنتيشن ما يكونش مجرد معلومات يعني جامده، فانا حاولت ان انا اجيب لحضراتكم samples of what we mean by hoarseness and breathiness. فلو حضراتكم تسمعوا الصوت
1 2 3 4 5 6 7 8 9 10.
This is what we call hoarseness, while breathiness
1 2 3 4 5 6 7 8 9 10.
So what are the causes? Causes for hoarseness is mainly due to deposition of proteoglycans. So this is a well-known information for undergraduate students. Proteoglycans or mucopolysaccharides or hyaluronic acid, they all accumulate in patients with hypothyroidism. They are known to be hygroscopic. They imbibe water. They swell, they enlarge in size, they lead to fluid accumulation and the formation of myxedema. This myxedema may affect laryngeal and respiratory muscles and definitely may affect the vocal folds. Patients may present with paresis of the vocal cords due to a compression by a goiter, and patients may even suffer from edema of the vagal nerve. As for slurring of the speech is due to dysarthria. And what causes dysarthria is again myxedematous swelling of laryngeal and hypopharyngeal structures, and also the swelling of the tongues or macroglossia. Both combined, they are known to cause dysarthria in patients with hypothyroidism. Complete glottic closure is essential for normal sound production. So in those patients who present with breathiness, so they are suffering from incomplete glottic closure. What causes this incomplete glottic closure is vocal paresis, which may be due to stretching of vocal folds, compression of vocal folds by a goiter, or swelling or edema of the vocal folds. The vocal edema will lead to increased vocal mass or increased vocal thickness. Also, muscle edema would change the myoelectrical activity of laryngeal muscles. They use the tool that they call dysphonia severity index to evaluate dysphonia in patients with hypothyroidism. And as you can see, they found a significant decrease in dysphonia severity index, and there was a negative correlation between TSH and dysphonia severity index, which means the higher the TSH, the more severe is the dysphonia in patients with hypothyroidism. One last parameter they used in the study was what we call maximum phonation time. The maximum phonation time is the maximum duration of the production of the sound Z. It measures the phonatory efficiency, and they found that it was reduced in both male and female hypothyroid patients. What causes reduction in maximum phonation time is an increase in focal fold mass, a slower rate of muscle contraction, which would lead to incoordination of the process of phonation and the process of respiration, both of which are required for maximum phonation. Also, maximum phonation is known to be severely sensitive to fatigue, and I have shown you that 10% of patients with hypothyroidism, they exhibit vocal fatigue. So to summarize the effect of hypothyroidism on the voice, hypothyroidism causes a number of voice-related symptoms. This is hoarseness, vocal fatigue, or slurring. Patients with hypothyroidism, they present with a hoarse or a breathy voice. They show significant dysphonia that is parallel to the severity of hypothyroidism. They also show reduced phonatory efficiency. Causes of these abnormal voice, increased vocal fold mass, incoordination of phonation and respiration, and some patients present with vocal paresis. مش كتير نسمع عن إنه الhypothyroidism may affect the voice, and we also have little evidence about this association. This is a study that was published in 2018. They have used a number of tools, one of which is maximum phonation time that we have already defined, maximum friction time, which is the maximum duration of production of the sound S. The ratio between these two parameters, also called the SG ratio, provides information about laryngeal efficiency. If this SG ratio is increased, this indicates laryngeal inefficiency. Laryngeal inefficiency means there is increased air leakage through phonation due to incomplete glottic closure. They also used what we call jitter, which indicates irregular frequency of the voice. So what they have found is that half of the patients who had hyperthyroidism presented with voice-related symptoms, namely hoarseness and low voice pitch. In these subjects with voice complaints, they had significantly increased SG ratio, they had significantly increased jitter, and they both indicated laryngeal inefficiency. As long as we are talking about hyperthyroidism, we should talk about radioiodine ablation. So would radioiodine ablation for patients who have Graves' disease would affect the voice? So this was a single study where they studied the effect of radioiodine ablation in patients with hyperthyroidism on the voice. They have used maximum phonation time, they have used the SG ratio, and they have used laryngoscopy. And these tools were applied pre-treatment 4 days and 20 days after radioiodine ablation. And simply they found that radioiodine therapy does not affect the voice quality. Very important question. This is ده عكس اللي بيحصل في الsurgery. Surgery may affect the quality of voice, but radioiodine ablation is completely safe regarding the voice. And then we go to thyroiditis, and specifically we're going to talk about subacute or granulomatous thyroiditis, which is now a well-documented complication of COVID-19. So this one single study, it was conducted by Sami Azar and his team, which is a Qatari team. They have recruited 22 patients with subacute thyroiditis, and they were compared to 33 matched normal control, and they have studied the patients for voice-related symptoms, and they have found the following. 60% of the patients had at least one vocal symptom. However, only 2 symptoms were significantly more in patients with subacute thyroiditis. The first of which is vocal straining, and the second was aphonia. Vocal straining is defined as having to exert effort to talk. And this is what we mean by having to exert effort to talk.
1 2 3 4 5 6 7 8 9 10
And the second significantly more symptom was aphonia, which is defined as loss of voice. And again, this is what we mean by aphonia. So what causes the vocal fatigue and straining? The first cause is vocal cord paresis or paralysis. How would subacute thyroiditis lead this? First, stretching of recurrent laryngeal nerve due to a goiter. Second, direct pressure on the nerve. A third, spread of acute inflammatory process and its mediators to the nerve. Fourth, perineural fibrosis caused by chronic inflammation. And finally, thrombosis of the recurrent laryngeal nerve vessels. Other causes may be due to changes in the vocal cords in the form of a change in rheological or viscoelastic properties, or may be due to neuromuscular fatigue, which would lead to respiratory fatigue. We have mentioned already that respiration is required for normal phonation. So this is for the subacute thyroiditis, and then we go to the next effect, which is goiter. Does simply having a goiter may affect the voice? So in this study, they have studied two parameters. First, do these patients have compression, which was diagnosed using Pemberton test and CT scan? And the second parameter was what they called perceptual voice profile. In this so-called perceptual voice profile, they have studied the voice quality, who's focusing on the roughness, straining, and breathiness, the pitch of the voice, and loudness of the voice. For each of these parameters, a numerical rating was assigned, starting from 1 and up to 6, with 1 representing normal, 2 slight, 3 mild, and then moderate, and then marked, and the 6 representing severely impaired. In the study, they had 47 patients with multinodular goiter, 12 patients with thyroid cancer, 21 patients with thyroid nodules. You can see that the rate of compression was 70%, 50%, and 40%. And in almost all the groups, they have found that the most affected parameters were roughness, straining, and breathiness. They were all affected only slight to mild range. However, in 10% of those with multinodular goiter and 5% of those who had a solitary thyroid nodule, there was significant rating. So again, just a reminder by what we mean with straining.
1 2 3 4 5 6 7 8 9 10
For breathiness,
1 2 3 4 5 6 7 8 9 10
and by roughness,
1 2 3 4 5 6 7 8 9 10.
just remember that only 1 in 10 or 1 in 20 patients will be presenting with clinically significant impairment. The last would be the relation between thyroid surgery and voice abnormalities. Certainly, vocal dysfunction is one of the most significant complications after thyroidectomy. 25 to 90% of patients report abnormal voice within few weeks after surgery, and 10 to 15% of these patients would still report abnormal voice 3 to 6 months after thyroidectomy. Not all the patients will have an abnormality of the recurrent laryngeal nerve. Many patients would experience voice problems with no evidence of laryngeal nerve injury. The typical causes of vocal dysfunction following surgery is either recurrent laryngeal nerve injury or external branch of superior laryngeal nerve injury. In recurrent laryngeal nerve injury, this leads to disturbance of mobility along with atrophy of the vocal cords. This will subsequently lead to a decrease in phonation time and an increase in amplitude and frequency disorders. While for patients who suffer from external branch of superior laryngeal nerve injury, this will cause a paralysis of cricothyroid muscle, and subsequently this is going to lead to a lower pitched voice, husky voice, easily fatigued, and reduced range of voice. About the incidence of permanent nerve lesions, luckily only 1 to 13% of the patients would suffer from permanent recurrent laryngeal nerve injury. This is largely dependent on the experience of the surgeon, and this would lead to marked dysphonia as a result of atrophy of vocal fold. The external branch of superior laryngeal nerve injury is permanent in 5 to 30% of patients. Again, it depends on the experience of the surgeon. However, those patients, even who suffer from a permanent nerve lesion for the external branch of superior laryngeal nerve, is going to suffer from subtle symptoms, and the patients will not feel as much handicap as recurrent laryngeal nerve. About the prevalence and the outcome of nerve paresis or nerve paralysis. So we have this study that included 220 patients, and you can see that 1 month after surgery, only 19 patients had paresis of the vocal cords, and 10 patients had true paralysis of the vocal cords. And this is an example of how a patient with paresis or paralysis would look like.
1 2 3 4 5 6 7 8 9 10
About the outcome in the first year of patients who would develop vocal cord paresis or vocal cord paralysis, we would start with the 19 who presented with vocal cord paresis. 3 months after surgery, 10 of these patients already recovered normal vocal cord movement, 4 were lost to follow-up, and 5 remained to have paresis. 6 months post-operatively, 2 recovered normal vocal cord movement, 2 were lost for follow-up, and 1 remained to be paretic. 1 year after the operation, this one patient recovered normal vocal cord movement, which means that in 1 year post-operatively, those who presented with vocal cord paresis will acquire normal vocal cord movement. While for the 10 patients who acquired true vocal cord paralysis, 3 months after the operation, 4 recovered normal vocal cord movement, 3 were lost to follow-up, and 3 remained paretic or paralysis. After 6 months, one more patient recovered a normal vocal cord movement, and 2 were lost for follow-up, which means that 6 months after surgery, among patients who would present with true vocal cord paralysis, 50% would recover normal vocal cord movement. A very important issue, in those patients who have normal movement of the vocal cord, would they still have or suffer from abnormal voice? Actually, many patients will have voice dysfunction without apparent paralysis of the recurrent laryngeal nerve or external branch of superior laryngeal nerve. What are the mechanisms then? The proposed mechanisms include laryngeal tracheal fixation by the scar itself, movement disturbance or malfunction of cricothyroid muscles or strap muscles, transient neural conduction disorder of recurrent laryngeal nerve or external branch of superior laryngeal nerve, finally, laryngeal edema, which may be induced by interruption of venous return or lymphatic drainage. Again, we have this trial. They compared total thyroidectomy to lobectomy to control. They all had normal recurrent laryngeal nerve and external branch of superior laryngeal nerve. They have used this tool, Voice Handicap Index 10, which measures the voice-related quality of life, which was not significantly different between total thyroidectomy, lobectomy, or controls. They have used this parameter, so-called fundamental frequency. Fundamental frequency is defined as the lowest vibration rate of vocal folds. And normality, this was not different among total thyroidectomy or lobectomy, which indicates that cricothyroid muscles and external branch of superior laryngeal nerve are intact in these patients. In cases of who have vocal dysfunction or laryngeal pathology, we expect a decrease in maximum phonation time and an increase in mean airflow rate. So in patients with total thyroidectomy, they have found a significantly shorter maximum phonation time and significantly higher mean airflow rate. And this was immediately after surgery, and it corrected 1 month after surgery. So these results suggest that patients who undergo total thyroidectomy, they have the possibility of having slight and a transient nerve conduction disorders, which would lead to slight glottic closure insufficiency. They also used acoustic analysis measures, and they have found in patients with total thyroidectomy compared to preoperative values, they had significantly increased jitter, shimmer, and noise to harmonic ratio. And in patients who had total thyroidectomy compared to controls, they had significantly increased jitter and noise to harmonic ratio. And all of these parameters normalized only 1 month after surgery. So what do we mean by jitter? Irregular frequency of the voice. What do we mean by shimmer? Irregular amplitude of the voice. And what do we mean by noise to harmonic ratio? It means increased noise component of the voice. What do we mean by the noise component of the voice? Kindly hear this.
1 2 3 4 5 6 7 8 9 10.
This is what we mean by the noise. So what causes an abnormality of these acoustic parameters? They suggested that thyroidectomy may lead to mucosal stiffness of the vocal cords. What causes the vocal cord stiffness? Inflammation and edema after surgery. Definitely having total thyroidectomy means that the surgical area would be much greater compared to lobectomy. So that is why in patients with total thyroidectomy, immediately after surgery, there is an impairment of venous return or lymphatic drainage, which would lead to inflammation, edema, and vocal cord stiffness. Having a rigid vocal cord is going to shorten the glottic closure time. It would demand redundant airflow during phonation, and it would cause irregular variation in both frequency and amplitude of the voice. As a final explanation, laryngeal edema would lead to vocal fold stiffness. This is due to disturbance of venous return or lymphatic drainage. This would synergize the occurrence of subclinical and a transient recurrent laryngeal nerve conduction disorder, both of which will lead to glottic closure insufficiency. To summarize the effect of surgery on the voice, following thyroid surgery, permanent recurrent laryngeal nerve lesions are less common, thank God, with more marked dysphonia. Permanent external branch of superior laryngeal nerve lesions are more common, however, with subtle dysphonia. About 70% of paretic patients and 50% of paralysis patients can recover during the first year post-operative. Following total thyroidectomy, not only neural mechanisms exist, but also non-neural mechanisms exist. So transient and non-neural voice impairment can occur. This is mediated by vocal cord stiffness or edema, transient conduction disorders of recurrent laryngeal nerve, laryngeal tracheal fixation by scar, or movement disorder of cricothyroid or strap muscles. I would like to thank you for being with us. Thank you for listening to this difficult topic. And I would like to thank my phoniatric students. So it is thanks to them that they have given me these samples of abnormal voice to show to you. So I would like to thank students of Master of Phoniatrics for providing me with the material that I have given to you. Thank you very much.
شكرا يا تامر، محاضرة رائعة طبعا. والله أنا كنت لسه